Hello, good evening and welcome to everyone. I'm Martin Kaplan and I'm a Professor of Gastroenterology at the Royal Free Hospital in London and across University College London. Welcome to the second in our series of healthcare talks, which is an educational collaboration with HCA Wellington Hospital, Kinloss and United Synagogue. Tonight, it's a great pleasure to welcome really a stellar quality panel of specialists. We've got Jenny Cross, nephrologist at the Royal Free Hospital, Clive Onney, gastroenterologist at the Whittington Hospital, Hugh Bainan, rheumatologist at the Royal Free Hospital, and Daniel Hochhauser, medical oncologist at UCLH. The way it's going to work tonight is that each panelist I'll introduce, and they'll have about 5 minutes of questions related to COVID and non-COVID topics. And then once all the panelists have spoken, we'll have a roundtable discussion. And please, you can ask questions. And so if you want to do that, you've got the chat box, which is at the bottom of your screen. If you type your questions in, we won't be able to cover all of them, but Shimon, I think, is going to be fielding them onto me, and then we can discuss some of those questions as well. I've had a couple of questions already sent in, so I think it should be a busy evening, an interesting evening. And hopefully it'll run a little bit better than the Zoom meetings from the Handforth Parish Council, although with some of our panelists this evening, you never know. So, and if everyone could mute themselves, except for our panelists, we're going to start off, first of all, with Jenny Cross. And Jennifer is a consultant nephrologist and associate professor of nephrology at UCL. She's clinical director for North Central London Nephrology Services and Renal Transplantation. She's the chief medical information officer for the Royal Free Hospital. She trained in Edinburgh before coming to London, completing her PhD in Patrick Valence's lab. And Patrick Valence, of course, is the government's senior scientific advisor. And Jennifer runs her clinical practice at the Royal Free Hospital, has a particular interest in the management of hypertension, diabetes, vascular diseases, and its effect on the kidney. And in addition, she manages a large cohort of dialysis patients, and she also has substantial experience in medical digital solutions and their development and deployment. So we'll hopefully also ask her some questions related to that. So welcome, Jennifer. Thank you very much for joining us. Let's start off actually with just a general question related to COVID-19 and the league tables that we have, where the UK seems to be doing rather poorly by comparison to other countries. What's your take on those league tables and the reality of it all?
So, I mean, it was made for terrible and grim reading when we reached that awful milestone of 100,000 patients in the UK who had died within 28 days of being tested positive for COVID-19. And pretty tragically, the Office for National Statistics created league tables, and England came top of that league table. And in fact, all the devolved nations were in and amongst the top 8 in the world for mortality for this terrible disease. England had an 8% excess mortality. And I think, you know, history will judge us. I think it's difficult to know whether our different measuring techniques in the UK compared with the rest of the world really means that this league table is real. But I do think when I reflect upon the experience of managing in-hospital services with colleagues, that when I watched what we were doing in the UK compared with other countries, it felt that we were tardy. So I would personally identify repeated delays in lockdown as a contributor. I think that the test and trace withdrawal were strategically absolutely the wrong thing to do in the early part of the pandemic. The strategy to discharge patients when we weren't routinely testing them for COVID-19 into care homes had a devastating effect. And in the first wave, something in the region of 18,500 patients died in care homes. And if you compare that with the second surge, something like 8,000 died, even though the numbers in the second surge overall were larger. Finally, I think it's something to say that, you know, the poor health status and health inequality in the UK as we went into the pandemic probably contributed something. Obesity, the prevalence of diabetes, and the common nature of hypertension, all of which are risk factors for severe disease. When you compare the UK to other island nations, such as New Zealand and Taiwan, who were really very effective in controlling the numbers, they had hardly any COVID deaths. I think we do need to look very carefully about the decisions that we made, and probably all of this will come out in a public inquiry.
Thank you. I think we'll come back to some of those points in terms of the lessons that we've learned, particularly when we have a roundtable discussion related to the variant forms of the virus and how we're going to deal with that down the line. Just in your own specialty of nephrology, how has the COVID-19 affected that?
When we started the pandemic, we were expecting a doubling perhaps of acute kidney injury. And what we actually saw was a vast increase in the number of patients who had kidneys that had failed as a result of this disease. And we really didn't have, we hadn't anticipated that. We first thought it was because patients with COVID became febrile, feverish, and lost a lot of fluid, or they were so breathless that they couldn't eat and drink. We then noticed that lots of patients presented with diarrhea, and there were many symptoms that they had that might have contributed to their kidneys not working particularly well. Some patients had biopsies so that we could look in detail at what the trouble was. But when we looked at it carefully, even when we corrected giving them lots of fluid to try and abate this acute renal failure, which numbered somewhere in the region of 50% of the seriously ill patients that came into hospital, much greater than had been reported from China or indeed Italy. We found that even giving them fluid didn't correct this. And there was a hard core of individuals who had quite heavy protein in their urine and blood in their urine. And that's often a sign that there's an intrinsic inflammatory type of kidney disorder. And when biopsied, we saw a variety of conditions in that minority. The other thing that scuppered us was that the types of treatments that we give in the intensive care unit when people are critically unwell to replace kidney function when kidneys are not working, we found that the demand on those consumables to deliver those treatments, the fluids and the pipe work, had been bought up both in Europe and in the United States. And there was a critical shortage as we entered into the first wave of the pandemic, where we had to do very novel treatments in the intensive care unit in order to give critically ill patients the kinds of treatments that they needed.
Thank you. I'm going to just, so that we open it up to non-COVID questions as well. Your specialty is chronic renal disease, and 1 in 7 patients, I think it is, will develop chronic renal disease. What is it and what causes it? And just tell us a little bit about your work in that field.
You're absolutely right. This is a very common disease, and it's insidious in the sense that it's often associated with no symptoms. If I were to look at 100,000 people and I were to ask just 3 questions of either them or their GP to try and guess who had chronic kidney disease, I would ask, do you have high blood pressure? Do you have diabetes? And are you a smoker? Because identifying those 3 things, those are the 3 things that define whether or not you've got artery disease. And that's the commonest set of causes of kidney impairment, in fact, in the developed world, but certainly in the UK. Of these people who've had failure of their kidneys such that they need to have dialysis treatment, 50% of that group, there's 25,000 people in the UK with that disease on dialysis, 50% of them is because of diabetes, and the rest of them, the vast majority, it's to do with badly controlled high blood pressure. And the rest, the very interesting stuff that I told you about, where there's inflammation in the kidneys leaking blood and protein, and my colleagues, Hugh Bainan and the gastroenterologists that might see these much more rare diseases, account for only a tiny percentage of the causes of kidney failure in the UK.
Thank you for that. So thanks, Jenny. We'll come back to you in the roundtable discussion. Moving on to our colleague Clive Onney. Clive is a gastroenterologist at the Whittington Hospital. He trained at the London Hospital before undertaking his PhD in the genetics of inflammatory bowel disease. That was at Guy's Hospital. He was appointed consultant at the Whittington in 2006, where he's the clinical lead for inflammatory bowel disease and the endoscopy unit. And he's well known to many at Kinloss as being the Gubby, the warden there as well for many years. And Clive, it's a pleasure to have you along this evening. You're normally telling me to be quiet in Shulp, and so you can't stop me tonight. First of all, in terms of, let's start off with COVID-19, and tell me how it affects the bowel and what your experience has been.
Thanks, Martin. Actually, as you know, medicine is my part-time job, and Kinloss tends to kind of occupy everything else. I think it's interesting, when we first started in the first wave, actually, my team at the Whittington sat down after about May time, and we essentially looked at all the patients coming in. We found that about 15, maybe even 20% of patients had some kind of diarrheal type illness, together with about 10% of patients having vomiting as well. Now, clearly, everyone associates, COVID with respiratory symptoms, the cough and the deterioration, needing to go to intensive care with, needing oxygen. But actually, there were a proportion of patients who had very few respiratory symptoms and actually developed bad diarrhea, and actually they all got better with just simple support. There was a little bit of concern initially that COVID was being excreted in the stool, but I think that was much less of a concern. And so, yes, a vast proportion of people were being admitted with diarrhea and occasionally with some vomiting as well. And the other thing that we were seeing is that quite a few proportion of people were having their liver enzymes in their blood tests were quite significantly elevated. And again, that was just one of the COVID effects which settled gradually with time. I don't think we're really seeing potentially patients with the kind of long COVID that a lot of people understand, be concerned about and suffering with. We're not seeing many kind of bowel-related long COVID symptoms at the moment.
And then you're an endoscopist, and undoubtedly, as we know, it's had a significant impact in terms of endoscopy. And what's your overview of how the service has been affected and the management?
I mean, back in April, May, we literally had to sit down and redesign the whole service, from actually how patients came into our unit, where they sat, where they were admitted, where they were covered, how many patients we could bring in, how we would screen them. One of the things that an endoscopy through the mouth into stomach was classified as was an aerosol generating procedure, and aerosol generating procedure with regards to COVID meant that certainly staff were much more at risk, and therefore wearing the kind of full gowns that the masks that people would normally associate with being on the intensive care unit. So we had to completely redesign that service. And I have to say, fortunately, at the Whittington, we actually had a lot of help, certainly from our management, which sometimes is not so forthcoming. And we were able to actually get up and running back in May very quickly. And actually, we were doing a little bit of work for some of the other trusts that were struggling to get back on track. So we managed to really redesign our services. Not only that, make patients, more importantly, feel safe, because in January time, as in 2 months ago, I think the Whittington, we made it top of the league tables at one point, with I think over 70% of our inpatients having COVID. And understandably, patients who were outpatient did not want to come near the place. So we've done a lot of work in reassuring people, in keeping the units separate from the rest of the hospital. We are screening all our patients, we screen doctors, and making it really as safe as we can. And actually, the service is getting up and running again, and that's true for us, and I know, for both you and at UCH as well.
And do you think we'll ever come to vaccine passports to get into the endoscopy unit then as well?
I think we will be looking at that, but at the moment we're screening patients, and screening is the most important thing. Yeah. So things are changing. We get emails every week about how long people have to isolate for, in their bubbles. So things are always constantly changing, but actually the most important thing is actually making sure it's a safe environment, and I think it is. And we've looked at all our patients, and we've not had any documentation of patients, evidence of patients actually contracting COVID as a result of coming through the units. And that's really important.
Yeah, absolutely. Moving off COVID, then just a general question. You're involved in bowel cancer screening, and it's much more prevalent in Ashkenazi Jews. What impact does this have in terms of the way we approach screening within the Jewish community when it comes to bowel cancer?
I thought you were going to be asking Daniel this question, given that he's the professor of oncology. But we know that for a variety of diseases, there's increased rate and prevalence in the Ashkenazi Jewish population, and the main thing we think is all about the genetic side of things. Because of the tendency of the population to marry within the community, therefore keeps any genes which may increase susceptibility to things like inflammatory bowel disease, bowel cancer within the community, and therefore kind of increases that prevalence. Whilst there is certainly no screening at the moment, and there are a few genes that have been identified as perhaps being slightly more prevalent in the Ashkenazi Jewish population, we also know that certainly at the age of 60, we should all be part of the National Bowel Cancer Screening Programme, which means that every 2 years we get invited to donate a bit of our stool and get sent off, and it's critically important that we all do that. But I suspect that as we go over the next few years, that actually we will start to introduce colonoscopy screening and at a younger age group. Because the one thing we are starting to see is that there's a slightly younger age group developing bowel cancer. And we're seeing that more and more the last few years. But at the end of the day, it is going to all be about being aware of symptoms and actually going to see someone about it and being investigated. And I think that whilst there is no screening program for the community, at the end of the day, there is plenty of availability of investigations. There are good non-invasive investigations of screening, and it's really important that we all make use of them.
Thank you, Clive. So going to move on. We'll come back to you again for the panel. It's a pleasure to now introduce Hugh Bainon. Hugh trained at St Bartholomew's Hospital in London, specialised in rheumatology. He held the prestigious Medical Research Council Training Fellowship whilst at the Postgraduate Medical School of Hammersmith. He was appointed subsequently consultant rheumatologist and physician at the Royal Free Hospital. Hugh is fantastic at teaching. He runs courses for general medicine for the MRCP status at the Royal College of Physicians. He leads general medical training for junior doctors at the Royal Free Hospital. And in addition to that, he's the medical director of the Wellington Hospital as well. So Hugh, you've been right at the forefront in casualty from the very beginning, dealing with COVID-19. Do you want to give the background to that, the story behind how it all took off at the Royal Free and the role of the front line?
Yes, well, thank you for asking me to come on to tonight's program. It certainly has been a most extraordinary year, and I think that we're now in the sort of coronavirus era. where I don't think things are ever going to revert to what they were before. But as you'll know, at the start of last year, when it became apparent that there was going to be a huge increase in coronavirus, life at the Royal Free changed forever. I used to do twice weekly early morning general medical ward rounds, and that changed to a daily general medical ward round. What was extraordinary at the Royal Free was how everyone came together and worked to combat the threat of this virus. And at the beginning, there was an awful lot of fear because no one really knew what was involved. No one knew how this virus was transmitted. No one knew how to stop it. And it's fair to say that at the beginning, we didn't have optimal protective equipment. There was a shortage of masks and gowns. So the fear factor was high. And interestingly, at the Royal Free, Rupert Negus, who headed up the coronavirus group, decided that we were going to divide into two teams at the start. There was going to be a red team. The red team was the danger team. So people who came through the front door were going to be identified as being definitely coronavirus, with the cardinal symptoms, as we know, of fever, cough, shortness of breath, and loss of sense of smell and taste. And then there was going to be the green team for everyone else who had non-coronavirus symptoms. And Rupert Negus looked at me and said, well, listen, you're getting on a bit. You've got white hair. We're going to put you in the green team to protect you. But it soon became obvious that everyone coming through the door with whatever symptom was infected with the coronavirus. Be they had neurological symptoms, cardiological symptoms, the diarrhea that Clive's pointed out, massive chilblains, massive joint problems. So in the end, I think we've seen more coronavirus patients on the green side than we did on the red side. Now, the other thing I'd like to point out, in addition to the teamwork that occurred within the NHS, is the impact that HCA have had on helping us cope with the coronavirus, because quite quickly at the beginning, it became obvious that we weren't going to have enough intensive care beds, and then the NHS was going to be full of patients with the coronavirus. So collaboration talks took place between HCA and the NHS, and the HCA have taken on most of the elective cancer surgical work down in its sites, as well as a lot of elective cardiology work, and that has continued to today. So it really has been a great collaborative effort all the way through. Now, what I would say about this coronavirus, this is a disease like we've not seen before. Initially, when people were planning for the coronavirus, everyone thought it was going to be the virus itself that was going to be the cause of patients' demise, but it's quickly become apparent that it's not really the virus that's the problem. It's the host, that is the patient's response to how it deals with the virus. And we've seen patients who've had huge immunological responses to the virus, the so-called cytokine storms, who've ended up in the intensive care units. And we've also seen that this virus, unlike other viruses that we've seen, has caused widespread blockages of blood vessels throughout the body. Jenny alluded to this in the kidney, but we've seen it right throughout, from the brain to the heart, through to the skin itself. So it's been an extraordinarily interesting time for those of us involved on the front line. And we continue to learn more about this virus every day. And I think there's a lot more to be learned about it than we know already.
And we've got now the new variants. And what are the implications from the UK variants to the South African variants? We've got the Brazilian variant. What are the implications of that? We'll come back to it in the round table, but just from a short overview.
So as we know, the government's view in this country, and I think we can criticize the government, but I think we have to applaud the government for its rollout of its vaccine program. It's certainly been a shot in the arm as far as trying to cope with this virus is concerned. You know, the great hope has been that vaccination will stop this virus or prevent severe disease. It doesn't stop people getting the virus or transmitting the virus. The problem is, as we know, that viruses mutate. Viruses have always mutated. So the fear is always, will the current vaccines protect against the new variants of the virus? And as you pointed out, the new variant started in Kent. And we know that that virus has been more transmissible. And now there are other variants coming through, the Brazilian, the South African virus. And the concern has always been whether the vaccines that we've got at present will protect against those virus strains. And the answer is we don't know. But I think we've all got to be jolly positive that whichever vaccine we've had so far will protect us against most of the severe side effects of the virus itself.
And just going on to those vaccines, what was your take on, we've got the different vaccines there, and then in France, when the president said, don't have your AstraZeneca one, what was your view of that, and what's your overall impression and the differences between the vaccines?
Well, Martin, if you'd asked me about the French prior to the weekend, you'd have a very different response. But having watched the rugby match over the weekend, where the French referee was biased towards Wales, I've got a slightly different answer at present. But I think the honest answer is, listen, we really don't know. There's an awful lot of politics in all of this. And the answer is we don't know. Time will tell. We're only a short period into the use of these vaccines. We don't know how effective the Oxford vaccine is against these new variants, or the Pfizer vaccine. So I think you alluded to before, politics is going to play a role in this, and it certainly does.
And then finally, going back to what Jenny had alluded to, in fact, what's the difference between March 2020 and March 2021 in the way you're managing the virus now?
Well, certainly we learned a lot over the last year about how to manage patients when they initially present with this virus. Interestingly, at the beginning, it was thought that many of the drugs that I use as a rheumatologist, such as steroids and many of the drugs that suppress the immune system, were bad news for the community as a whole if they got the virus. Now we know that it's exactly the other way around. So we know now that when people come in and they present in the early stages and they haven't got enough oxygen in their blood, that if we treat them with corticosteroids and some of the newer drugs that we use in rheumatology, that the prognosis is better. To answer the second part of your question, the demographics has changed. About a year ago, we were admitting much older patients from the care homes, as Jenny alluded to earlier. The current cohort have been much younger patients, okay, without the previous comorbidities. And they've often tended to be sicker with multi-system disease. So we have seen a difference in how this virus affects different cohorts of the population.
Very good. We will come back to you at the roundtable discussion. I remember going down in the first week to casualty with the red and the green teams there, and I went down to see the patient, and we had it was a notes trolley that was separating the red team to the green team. I thought, how's this notes trolley going to stop the virus coming? I had to, and of course the notes for the patient were in the notes trolley, and I wasn't quite sure which side of the line I was on, but that's how crude it was at the beginning.
But just to paint that bigger picture, Martin, that's really what it was, wasn't it? And there was a trolley about 3 foot dividing the accident and emergency department into the red side and the green side.
Yeah, there was very good. We shall come on to that further. Now, finally, it's a real pleasure to introduce Daniel Hochhauser. So Daniel is the Kathleen Ferrier Professor of Medical Oncology at UCL, consultant medical oncologist at UCLH. He specializes in gastrointestinal cancer. His research is focused on the development of novel targeted therapies. He has a big laboratory program at UCL at the Cancer Institute. And he's head of the research department of oncology at UCL Cancer Institute. And he's also the cancer lead for the UCLH Biomedical Research Center. So Daniel, it's great to have you. In the year 2019 and comparing to 2020, 50,000 fewer people were diagnosed with cancer in the UK, which will be related to COVID-19. What are the implications for cancer services regarding diagnostics and treatments with the delay now in diagnosing and treating patients?
First of all, thank you very much for the invitation. And it's wonderful to be such great colleagues and all the different perspectives. Nobody ever asked me the color of my hair for some reason when they're deciding how I would be allocated. I think Martin had this. But anyway, in answer to your point, the differential diagnosis, the missed or less of cancer are very important. Obviously, the major reason for this is that the presence of cancer at an early stage, because a number of people have been or come with symptoms for diagnosis of cancer was reduced in terms of reduction in endoscopy, which Clive has already identified. Most patients with cancer are diagnosed by gastroenterology, virtually all, who have been either undergone screening or routine colonoscopies and other cancers for endoscopy, and those were, and for good reason, the demand was outstripping the supply of these in the beginning. So that led to a number of cancers that, of course, unfortunately, will be delayed to a later process, to a later time when they will be, of course, advanced and the prognosis may be worse. That is one issue. And of course, that same argument applies to cancers such as lung cancers and so forth. So the effects will be seen further on downstream. In terms of the actual treatment of the cancers, COVID, of course, has also had an important impact. Surgical services were initially disrupted, although I think now in the Royal Free and elsewhere, they have actually returned to normal. So once the patient is in the system, I don't think there are as bad delays as there were previously. So that's good. In terms of treatment of patients with chemotherapy and systemic concern in the beginning, dangerous thing of COVID, and there were quite rationing rules of what chemo schemes and which patients could receive treatment. Actually, were only there for the first 1 or 2 months. Then patients have been, my experience in good centres like the Royal Free, UCLH and elsewhere, are receiving the same treatment as they were before. I think the problem is not oncology and it's not surgery, it's the patient not presenting with symptoms. And actually, that is a big issue, I think, in the UK. And I think the effect will be these later. So it's very important that patient symptoms like this new onset of symptoms that should not say it's dangerous to get a consult GP, it's to the hospital, because actually
Daniel, we've got there's a delay on your line, so we're missing some of what you're saying.
How do you do it? I'm going to go on. I'm going to switch. Sorry, there's something wrong with my. I'm going to switch to the iPhone. Can you hang on? Excuse me 1 moment while I just
you do that.
The system. 1 minute.
I'm
here. I'm okay. I'm on yours. Yep.
Yep. You're okay.
It's just coming on Joe's iPhone. Yes, I'm going. Joe's, the network could not be found. Joe, switched on your iPhone. About this, it's pathetically amateurish. I'll put it on mine.
One of the leading academics.
Okay, this should be better now. It should be better. Sorry about that. I don't know how much of that came through, but basically, it's a bad thing. Essentially, diagnosis was delayed, and we will work on that now. So apologies.
Now, in terms of the actual effect of COVID on cancer treatments and delaying patients their chemotherapy or advising them to say to have their vaccinations first, what's your policy?
I think vaccinations can continue. There's no evidence that chemotherapy interferes with the vaccine. I mean, it's preferable to get it if one's finishing a course after you've completed it, but there's no evidence that there's any impact on the efficacy of vaccination for most regimens. In terms of the treatments, as I say, they are continuing. There have been a number of studies with opposite results, sometimes suggesting that there's been a negative impact on treatment of COVID. But overall, looking at the balance, I think patients can be treated safely. And there has been some benefit as well, actually. I think there's been a rationalization of some of the chemotherapy regimes. Some patients who were being treated, for example, adjuvant treatment of colon cancer in 6 months have been moved quite reasonably to 3 months. This was something that there was good evidence for. This is what we call the adjuvant treatment. A number of patients after the surgical removal of the cancers, and it's accelerated more rational protocols and more rational treatment decision making. So it isn't all negative, and as I'm sure is the case in everybody that we've heard of today, we work a bit more rationally. A lot of patients were making journeys up to the clinics, spending an hour getting to the clinic, 3 hours sitting around in the clinic, and an hour back. wasting their whole day on it. And now we see that we can do this by video calls or by phone calls. Obviously, it's nice to see patients face to face, but for simple treatment decisions, they would rather just have a phone call at home if it's straightforward.
Okay, thank you. And now just moving on to cancer research, how do you see us being able to diagnose cancer earlier?
So I think earlier diagnosis is the key to the future, and there's genuinely a revolution at the moment in that respect. So there are cancers in which the screening is okay. There's mammography, of course. There's cancers in which screening is not so proven to be efficacious, such as prostate cancer, PSA screening. It's contrasting evidence from that. And there's cervical cancer where it's extremely effective. So you've got that's been around for some decades. Now we're moving to a new situation. What about targeted screening? Instead of screening the whole population, target the population at risk. For example, papers in the New England Journal and a recent study from Sam Janes at UCLH looking at screening smokers or ex-smokers with CT scans for lung cancer. You clearly will pick up and improve mortality by doing that. Whereas if you did that in the whole population, your yield will be poor. So that using our existing imaging better, it would be a very good way forward. The problem, of course, is you need more radiologists, you need more scans, and where do you provide those from? But leaving that aside, I think earlier diagnosis we're already seeing in colonoscopy. We see already, given the routine NHS screening program, we're already seeing more early stage bowel cancers. It's clearly obvious in each place that we're improving the outcome of bowel cancer. And the next stage on is really looking for even more sophisticated techniques to identify cancer. And that has yet to be proven, but is potentially most exciting because it's clear that cancers shed their DNA into the bloodstream, that one can actually pick up tumor DNA, circulating tumor DNA in the bloodstream. That technology is already in use in patients with advanced cancer. We actually use that technology to look for mutations. The question is could you use that to actually determine the progression of a cancer before it could be detected in any other way? I'm sure people here know the company Grail, which has just done a major study in looking at this. It's still not proven, but actually there's a lot of studies suggesting that you can detect circulating tumor DNA in the blood prior to you actually detecting the cancer radiologically. And the same applies to the treatment of cancer. I mean, when a patient has a bowel cancer removed, if their lymph nodes are involved, we treat every single patient with chemotherapy, even though quite a number of those patients have already been cured by the surgery. So a number of patients are basically getting chemotherapy when they have already been cured. How do you identify the high versus the low risk? These technologies, such as circulating tumor DNA in the blood, will allow us to not treat patients unnecessarily and to focus on those people who are at risk. So it's a very exciting time in that respect.
Thanks very much. Let's open up now to the panel. So all our speakers will have input from all of you. Hugh, we'll start off with a very quick question related to chilblains, and everyone's talking about it. GPs are seeing a lot of it. You mentioned it. What's the connection with chilblains? And he's got the photo there, chilblains and COVID.
So chilblains historically have been associated with exposure to the cold, and they're small little venous infarcts. But we've seen an explosion of chilblains associated with coronavirus infections. It's commonly known as COVID-2, and it is due to inflammation of the small blood vessels. And if you actually take a sample of that blood vessel out, you can see that there's an infiltration of inflammatory cells in those blood vessels itself. So it's another manifestation of coronavirus infection. And it actually tends to go along with a fairly good prognosis. Patients who develop the chilblains tend to have very high levels of what's called alpha interferon, and they tend not to get the severe lung manifestations.
Thank you. Now moving on to a more general point. Jenny, you were talking about the mistakes that we had made first time around, and now we've got the variant. And how do you see us? How are we going to take forward the lessons we've learned, and with dealing with the variant, and in terms of screening? What's your view on it?
Yeah, I mean, we're moving in. Schools go back on the 8th. I've got 2 school-aged children. They go back on the 8th, and there's lots of this lateral test that they're doing. I think the government, as Hugh said, it's very easy to look back and criticise. We were in a situation of emergency with a dearth of information. And I think we've learned a huge amount. And what I'm seeing in the first 2 months of 2021 is a pleasant caution, so that there's quite a thoughtful approach to how we open up, that it's slow and it's cautious. And I think that's the right approach. I think the things that we've learned in terms of the vaccine, Hugh's absolutely right. We just don't know enough about this to know what the impact is. But we've got some very early suggestions that the vaccine in the over 80s is protecting patients such that they are not hitting our intensive care units as they did so much in the first surge. And it's enormously reassuring that the precautions that we've taken the second time round compared with the first time round has had a massive impact in terms of the reduction in the death rate of patients who are frail, over 70 and in nursing homes. So I don't think we're going to get all of this information sorted for a long time to come, and I await, sadly, the review, no doubt, that will be asked for in the decisions that were made at the time and what information is available to them. And I do think that my kind of plea to everybody out there is, if you're nervous about having the vaccine, please don't be. It's safe, it's effective, and it may well save your life.
And on that point of the vaccine, do you want to comment, or Hugh, do you want to comment on the delay in the second vaccination? What's your view? Has that what's the impact been?
I'm happy to share my view. My view from the data, looking at the way that they interrogated the first vaccine and the AstraZeneca vaccine in the trial, there was quite a big variation in when that vaccine was given, and there's no evidence that a delay in delivery of the vaccine has an impact on the responsiveness when a patient is exposed. And we've seen very, very reassuring percentages of patients who have had the vaccine who, when exposed, don't get the disease, even after the first vaccine, of the order between 60 and 75%, depending on the studies that you look at. So my personal view is that it makes little difference. The Pfizer vaccine, they were absolutely rigid about when they gave it at 3 weeks. But there's no sort of technical reason why it should behave any differently in terms of protection.
Can I come in on that? Helen actually gave a very informative talk at the Royal Free about 3 weeks ago and pointed out that often the immune response after 12 weeks is actually much stronger than after 3 weeks. So I really would reassure people enormously. I don't really think it matters when they get their second dose.
Mm. I had a question that came in. Can people with allergies be vaccinated?
Absolutely, yes. It's a very narrow group of patients that are excluded, and it's people who have, very serious anaphylactic reactions that carry an EpiPen and need to use it. Those are the group that we're cautious about. But certainly people who've got modest or mild allergies, we shouldn't be worried about having the vaccine. The risk of not having the vaccine, in my view, is much greater.
Now, thinking of things generally, if we're thinking of going away on holidays or opening up the country, of course, unless everyone else in the world is vaccinated and you can suppress the virus globally, actually, we're all going to continue to be in trouble. And that has big implications in terms of, as I think it was Jenny who said about people buying up treatments and vaccines and the inequalities there as well. So I'll go to ask Jenny first of all, because I know that it's something she's thought about. And Daniel, just from your perspective of the politics of it all, I'll come to you second. But Jenny.
I mean, very briefly, we are none of us safe until we're all safe. And that means that, I feel really strongly that we need to be trying to be egalitarian about the sharing of our resources. And we've seen the beginning of that organised through the WHO, and I would be very, very supportive of that.
Mm. Daniel, any comments just related to the politics of all of that?
What do you mean by the politics? I'm not.
Well, in terms of, countries buying up vaccines, and then so it's always going to be, in fact, I doubt whether in Brazil they may have the same ability to vaccinate the whole population as in the UK, and you've got people there who, and of course, when you're coming from poorer backgrounds, you're much more prone to getting disease, and you're much more prone to being having a higher mortality related to COVID as well as other diseases?
Well, I don't have any expertise in this, but I mean, Israel's quite interesting from the standpoint of the fact that it has the most staggeringly successful vaccine program in the world, but also a very unsuccessful lockdown process. So basically there, you saw what happened with very good vaccine when you have a tremendous rollout of a vaccination, and then you have like huge chunks of the population of Bnei Brak and Mea Shearim who are essentially not keeping to any lockdown at all. It's interesting what's happened. I mean, although it really is not as good as here, the lockdown, nowhere near as good as in this country, there is, of course, a steady fall showing the efficacy of vaccination. In terms of other countries, Brazil's got this lunatic president. So, I mean, you know, that's not politics. The guy's deranged. So, I mean, there's not much to say about him. I mean, each country has its own politics. I mean, for all that Trump had his issues, he did actually push the vaccine program, although he, of course, hung out with some rather unsavory types in many ways, and in fact denigrated a large amount of the expertise he had around him from Fauci and others. The actual vaccine program started quite well under the last American president. So each country has its own culture and its own politics, how it does it. You can't really generalize how things are. And I think Jenny pointed out the island issue. I mean, of course, New Zealand is stunningly successful, that they shut themselves off at an early stage, were very, very good at track and trace, and they've had no, you know, pretty much no cases. And then they've actually been slower to introduce the vaccinations than us. So it's mixed, each country. We used to say the Germans were wonderful. I mean, the Germany started off brilliantly. Now the German mortality is going up, and they've completely messed up on vaccination. So it's a balance in each country.
And Clive, in terms of this, you know, it's been remarkable in terms of the speed of development of clinical trials and treatments. What's your thoughts in terms of the future opportunities related to that in your specialty and beyond?
I think that the one thing that is going to change is how we do things, and that's going to affect research as well. So the use of medical, you know, software, digitalization of things like you know, artificial intelligence, and how we apply it to our trials and how we apply it to our research as well. And that's going to, I think the whole last year is really, you know, forced us to kind of look and change how we do things, both the clinical, you know, day to day, but also how we want to actually pursue things on a research basis. And that you know, that there's been a huge kind of, I think, effect from that. Regards to gastroenterology and where we're going, we're doing more things now in endoscopy and taking out bigger lumps from the people's bowels than we ever used to do 5 years ago. You know, what we would hand over to surgeons these days, we are doing in endoscopy. We're going to find that artificial intelligence, I think, becomes more and more of a role in the next 5-10 years. You know, instead of one pair of eyes looking at a screen at a colonoscopy looking for things, we're going to have, you know, someone perhaps on our shoulders trying to point it out as well. So, and in my world,
I'm going to cut for the sake of time. Daniel, in terms of the clinical trials that we've been able to do expedite so much more rapidly in related to COVID-19, do you think that there's ways that can be applied to in oncology and in other situations?
Yeah. I mean, the vaccine trials are a triumph. I mean, it's just incredible how quickly the vaccine's been rolled out. So, and that does provide a route for saying how quickly things should be done. I think in terms of just following on from what was said about research, it should be noted that a lot of the research in this country is funded, and much of it is government funded through the Medical Research Council, but a huge amount is funded through philanthropic bodies, the Kidney Research Fund, the British Heart Foundation, and of course Cancer Research UK involved with, and they've had a huge drop in income over the last year. I mean, Cancer Research UK has dropped almost 40%, and I think overall it's about 38% the drop in income. That is going to have an impact on medical research and also trials that are led by academia. So, but in answer to your point, trials are still not going properly at the moment because of COVID, because a number of the staff, for example, at UCLH and I think at Royal Free have been diverted to looking after COVID patients. And so there have been less staff available. Assuming that comes back and we go back on the trials, yes, I think the beneficial effect of COVID is going to be more rapid, getting rid of the bureaucracy, getting trials registered more rapidly and push them through. That will certainly happen. I mean, I don't know how many trials, and the Royal Free people will tell me it's the same in UCLH, how quickly these clinical trials are, as an idea is thought of and how quickly they are implemented. It's astonishing how quickly new agents and combinations can be looked at. Those are big lessons to learn for all diseases in the future.
Hugh, you know, in the early days, hydroxychloroquine was being given to patients and with very little evidence base. And what was your view of that? And you had Donald Trump and saying you drink bleach or whatever it was. Or in terms of the treatments coming through for COVID-19 and also the cost of treatments as well. And Jenny, we'll come back to you related to that and maybe discuss plasmapheresis and these sort of things.
So I think the first thing to say is the most important drug is dexamethasone. That has been shown in the recovery trial to really alter the outcome of patients who are sick with coronavirus infection. But there are many other newer drugs that also been used, such as tocilizumab, which is one of the specialist drugs we use in the treatment of rheumatoid arthritis that targets more specific molecules. Look, I think at the beginning of this, people were using any drug they could, from hydroxychloroquine through to colchicine. And now at the moment, everyone is trying various potions and lotions. I mean, there'll be turmeric and glucosamine and chondroitin, everything will be coming to the fore, really. But I think we do need some reasoned thought. We now understand how this virus causes pathology by stimulating the immune response. There's a cytokine storm by causing widespread clotting of the blood vessels. And I think there is a much more thoughtful, targeted approach now to how we should treat these people. But the one plea I would like to make, we've spoken about people obeying government lockdown targets. Jenny spoke about the importance of vaccination. But the simplest thing that people can do to protect themselves from this virus and from the other viruses that are going to follow is physical fitness. And I cannot really underestimate how important it is to be physically fit, not to be overweight, not to have attendant diabetes and hypertension that goes along with it, because it really does increase your chance of surviving any of these virus infections.
Jenny, any comments? And then just
yeah, no, I'd very much second that. We call it physiological reserve, and a member of my family is a professional athlete, and his comment to me was always, the biggest impact that you'll make on your general health is from going from doing nothing to doing something, doing anything, whether that's just walking up and down your stairs 2 or 3 times. It does not require a gym membership. It does not require any fancy kit. It just requires you being out of the house, walking around the block, walking up and down your stairs. You alluded to a couple of things that I wanted to pick up on, and one was the kind of role of artificial intelligence in our lives. And of course, it was amusing. I noticed, Daniel, that you had a little helper in your house when your IT went down. And I bet that person didn't have grey hair and was 2 or 3 or 4 decades behind you. Was it your?
No, it actually was my wife, but she's still.
I take it all back then.
Yes, she does.
I take it all back.
But does look several decades younger than me.
So generally, what we know is that the people that are coming behind us, our registrars, our medical students, are profoundly more, able in the realm of digital than we are, and actually we've got to make way for them. Artificial intelligence is going to be really important in almost all aspects of medicine, and particularly Dr. Oni mentioned early diagnostics. And we know that we've already got 2 or 3 systems for diagnosing breast cancer. Instead of having 2 radiologists looking at imaging, we have an artificial intelligence program that we've trained to spot it. And then we have a double check by a second radiologist. And this is going to really revolutionize the speed with which we can get through. We know that in some instances, for example, in retinal diabetic eye screening, that the machine's better than the primary operator. Is that going to put us all out of a job?
No.
I think almost certainly not, because there's some art to what we do that is not just about coming up with a black and white answer. I think we're always going to need a doctor to do the human side of things, but I do think that it's going to make us more efficient and effective. I've said that so that I can have some contention from the panel.
So yeah, Hugh could hardly stay in his chair there, because we were talking about it last week about how they don't get out their stethoscopes to listen to the heart. Hugh, come back on that, please.
No, I think we have to combine both. Clinical medicine is certainly not dead. Okay, it's an art. It needs to be handed on from generation to generation. Okay, but we need to combine that with new advances. Absolutely, but both are equally important.
Mm.
But you're right. We now see a situation where when someone has abdominal pain, people would sort of hesitate to come down and make their clinical assessment until they've seen a CT scan. And I think that's absolutely not the right way to go forward, because there's some very simple things to be done to make very good diagnostics if you're looking properly and carefully.
Can I follow that up with a story? At a hospital that I will not name, there was a patient who arrived in A&E with abdominal pain and was vomiting. And the surgical registrar said to the A&E, I'd like you please to do a CT scan before I come and examine the patient. And when they did the CT scan, they diagnosed that she was pregnant.
On that note, actually, we had a question about vaccination for COVID and being pregnant and pregnancy. Are there any issues with that?
No.
So, okay.
No, it's perceived as being safe.
Yeah.
As Jenny said earlier, the dangers of catching COVID far outweigh any side effects from the vaccine.
And Jenny, you specialize in medical digital solutions as well. Just tell us a little bit about that.
So, I mean, we've done lots of work trying to find better ways for doctors to work, but frankly, the most important thing is to improve the ways that patients can look at their own information. And I think that the move forward in the next 5 years or so is going to be all about distance monitoring, and that is sort of patients owning their own symptoms. And we've alluded to it with Dr. Oni and Professor Hochhauser saying, actually, you do need to notice your symptoms. You need to be recording and thinking about what's going on so that you can direct your entry into medical assessment. And I think there's going to be some really clever ways where we can help to use digital solutions to allow patients to tell people what's going on with them from their own home. And I don't just mean digital, video conferencing or telephones. I mean recording things like what's in their urine on a dipstick, what their weight and their blood pressure is routinely coming into hospital, what their saturations are if they're breathless, and digitally trying to get that to come from home to hospital so that we can enrich the interaction between patients and doctors.
Martin, can I come back on that?
And then Daniel was had his hand up. Go on.
Jenny, I agree entirely with that. But the other important thing is patients have to take responsibility for their own disease. They have to take responsibility for monitoring their blood glucose, for keeping their weight down, for taking their medication. We can only do so much.
I completely agree. And of course, that's going to be writ large as the trends in our population continue, which is increasing obesity, increasing diabetes, which is like a polycomorbid problem. And we're so clever, I think, in medicine at fixing some of these things. We sometimes forget when it's right to fix it and when it's right not to fix it. And we actually put, I think, on occasion, patients through, a huge amount of suffering because we think we can do something when actually sometimes it's not the right thing to do something.
Daniel, did you have?
Yes, I mean, I just would dissent that medicine is going to continue when we're going to be needed. I actually think a lot of medicine is going to become obsolete actually in the next 10 years, if I could introduce that. I think my own specialty will become mainly obsolete because a lot of oncology is very algorithmic. If this, then this, if this, then this. And there's no reason why a decent computer artificial, there has been an attempt to do this actually called Watson in the United States, which failed for various localized American factors. But a lot of the decision making that we do in cancer, and of course Hugh pointed out what happens when you practice bad medicine, and of course there's cases that are unusual, but for majority of the cases, the question is getting a uniform good standard of care, and a decent algorithm could do that. Now clearly that has to be applied to the individual patient. It's not going to be treating a 90-year-old with severe strokes in the same way as you're going to treat a 35-year-old. But at the moment, a lot of the decision making is somewhat arbitrary. If you look and see how different doctors assess patients' fitness, it's called the art of medicine, but it's a strange art, more like Jackson Pollock. It's basically somewhat arbitrary how patients are assigned performance status. And I don't see why a lot of what we call medicine, there will clearly be a role for doctors in research, there will clearly be a role for doctors in leadership, there will clearly be a role in unusual cases, but I think a lot of the medicine is going to be computerized. And if you look at radiology for this screening of lung cancer, I don't see that radiologists are going to sit there looking at thousands of CT scans. Just as was said with the case of the retinal display, I think the same will apply to mammography, the same will apply to chest CTs, the same will apply to digital pathology. Obviously, there will be cases that need experts to there, but do you need to have consultants looking and doing all of these thousands of screening tests? I don't think you will. So there will be, I think, always a need in medicine to improve and to communicate and to develop the human side and to make decisions. But a lot of what we do in decision making could be taken over by computing and artificial intelligence. So I'd be more pessimistic about whether we need so many.
Can I come back on that and say we've got two excellent examples of people who said that medicine and science will reach a natural zenith and will become obsolete. So Linus Pauling said that and was proven dreadfully wrong. And Aneurin Bevan said that at the inception of the NHS. And of course, TB went, and that was the big killer. And it's just it's not a static audience because the people we're treating have vastly changed over the time of the National Health Service. So that's my challenge to you.
Well, Aneurin Bevan, of course, famously said he'd stuffed the consultants' mouths with gold, actually. But that was because at the time, that was the limits of medical progress. But he was a politician. He didn't have any a brilliant man, actually, but he didn't have an insight into there were no treatments then for many of the medical conditions. And Linus Pauling was a genius who won actually 2 Nobel Prizes, but he also went a bit bonkers at the end, actually, with his high dose.
He had a vitamin C moment, didn't he?
And actually, he got it wrong sometimes. So I don't think medicine's reached its zenith, not in any way. On the contrary, I think there are massive challenges to do, but it's just a lot of what I do could be done by a decent computer. And then, I can surf the net for the rest of the day.
On that note,
Martin, it's quite interesting to come back to say that the coronavirus, when it causes sickness, causes people in the intensive care unit to rely on medical students to turn them at regular intervals.
Yes, the proning. You're talking about the proning.
I'm talking about proning. I think that we need to really shout out to all those people who work jolly hard in the intensive care units, keeping those patients who've been seriously sick alive.
Yeah, absolutely. It's the
basic
things which actually can be the most effective. And as you say, proning, turning the patients in ITU, done by unqualified people, and those surgeons who weren't able to operate were just there just to turn patients. And absolutely, that definitely saved lives as ever. The simplest things that often make the most difference in medicine. And also a big one can't give a big shout out to those GPs who are giving the vaccinations to the patients and at such fantastic rates at the moment as well. I think we're way over time that we plan to finish at 10 to 9, but it's been a very enjoyable evening. I hope that everyone has enjoyed this debate this evening and learned something about coronavirus, but also looking to the future in terms of the artificial intelligence, how that's going to be used, and some other medical advances that we've covered tonight. I think there will be some feedback form as well for you to feed out, to fill in. And just to mention that the final episode will be in April, on April the 13th, which is going to be looking at care of the elderly. I think actually Hugh Bainan returns for that one. We're obviously working you doubly hard, Hugh. But otherwise, I want to thank our panel this evening, who've been really excellent. That includes Clive Oney, Hugh Bainan, Daniel Hochhauser, and Jenny Cross. Thank you to all of you. It's been a pleasure to have you on. You've been great. And to all of you who've tuned in this evening, thank you as well. I hope you enjoyed it, and join us for our next episode. So thank you very much. Have a good evening.
Thank you very much.